So to put this topic in context, we all exist along this spectrum somewhere, and most of us won't ever have much to do with implantable hearing devices. You'll have all come across bone-anchored hearing aids, which a lot of general ENT surgeons do, and I'm sure you've come across them in your training. But the more complex hearing implants are really up at this end, and they're done by subspecialist otologists. In Manchester, as you've already heard, there are 3 of us that do just subspecialist otology, and even within our department, our experience of these devices is limited. And that's the case across the UK, really. There's a few pockets of colleagues around the world who have large practices with specific devices for whatever reason. But the UK practice regarding these devices is really very limited, and for that reason, a lot of the literature is at very early stages. Your FRCS examiners, however, will want you to know something about these, and so I'm going to try and gear today's talk towards things that I think you probably need to know or that might be useful for your exam. Although we're going to go through these devices today, I would add that there's no substitute for tracking down a colleague and going through these topics in real life with them, because, for example, in your exam you could well be given one of these devices, and if you're very familiar with them, it's obvious what they are. If you're not familiar with them, they look pretty similar, and you might struggle to calm yourself in the exam and say that this is a cochlear implant, this is the electrode that goes into the cochlea, this one's a vibrant sound bridge with a floating mass transducer on the end, and this one's a bone bridge that goes into the mastoid. If you come to meet one of us in person, you'll also get to have a look at some other devices. These look very similar, and in the stressed environment of the exam, you might wonder what the difference is. But once you know them very well and you're familiar with them, it's very obvious that this one's a hearing aid and this one's a cochlear implant processor. And you'll really appreciate that well if you hold one in your hand and just get to know them and become very familiar with them. You'll be doing really well in your exam if you're shown either of these devices. These are the single piece processors. The one on the left is for a cochlear implant, and on the right is for one of the middle ear implants. So I didn't realise this was a national study day, and I was going to invite you all to come to Manchester when the time comes for your exam. If you are in reach of Manchester, do get in touch when the time comes and you want to get to know these devices better. But actually there are lots of centres around the UK, local to you guys, where you should go along, meet your colleagues and just learn a bit more about these devices. I certainly, at the time of my FRCS exam, hadn't come across any cochlear implants or any middle ear implants and didn't know anything about them at all. So, back onto the topic, why would you choose an implantable device which is much higher cost, a much higher risk to your patient than a standard hearing aid? And there are 2 main reasons for this. One is for patients who don't benefit from their conventional hearing aids and might benefit better from an implantable device. And the other is for patients who can't use conventional hearing aids. And these fall into 2 main categories. One is anatomical, and they're patients who have a microtia or anosia. The other is patients who have a chronically discharging ear and just can't wear a hearing aid in the longer term. So are there any questions about that before I talk about classification of these devices?
So no questions yet, Emma?
No questions yet, excellent, okay. Because I'm on full screen, I can't see the chat anymore, but perhaps you could just let me know if there's any bursting questions.
Yeah, will do. If you just, as I said, take when you want questions, just say.
Brill, thank you. So certainly as a trainee, I used to think classifications were devilishly complicated because you had to memorise them. There was no easy way to remember them. But actually, in terms of implantable hearing devices, you already very much know the principles that apply to them. And these are 3 main principles: amplification devices, bone conduction devices, and devices which bypass the ear altogether. Amplification devices work on the same basis as a hearing aid in that they take sound from the outside world, make the sounds bigger, and deliver them to a part of your ear which can appreciate them or hear them. Bone conduction you're all very familiar with from bone-anchored hearing aids. This bypasses the external auditory canal and the middle ear and delivers sound directly to the inner ear, which I still think is a bit of a miracle. And these devices which bypass the ear, I'm not going to speak about in great detail because Simon and Deborah are going to speak about them later. But just to briefly mention, cochlear implants, although the implant is in the cochlea, it's actually bypassing the cochlear hair cells and it's stimulating the cochlear nerve. The one below is an auditory brainstem implant. This bypasses the whole of the inner ear and the cochlear nerve and sits on the cochlear nucleus of the brainstem. So these are just different ways of delivering sound to your patient. So amplification devices are useful for patients with a moderate to severe hearing loss, and they can apply to any type of hearing loss. You can amplify sounds and deliver them to a patient with a conductive hearing loss, a sensorineural hearing loss, or a mixed hearing loss. Bone conduction devices are more useful in a conductive or mixed hearing loss. And the devices which bypass the ear altogether, which Simon and Deborah are going to speak about, they apply to patients with a profound hearing loss who don't benefit from conventional hearing aids or any of these other type of devices. So if we come back to this slide that I showed you earlier of the 3 devices you might get shown in your exam, they each belong to one of those categories. So for example, the cochlear implant belongs to the category which bypasses the inner ear altogether and delivers sound to the central nervous system. The vibrant sound bridge is an amplification device that makes sounds bigger and delivers them to a part of the ear where they're useful. And the bone bridge is a bone conduction device. So if we come back to our classification, looking at just the amplification devices and the bone conduction devices, the amplification devices are active middle ear implants. They're sometimes called implantable hearing aids. And you can classify these as either being partially implantable or fully implantable. It's pretty simple. Regarding the bone conduction devices, these are bone conduction hearing systems, and they can be classified as either percutaneous or transcutaneous, and active or passive. Any questions about those classifications?
Nothing yet, Emma.
Okay, I'll crack on.
Crack on.
So the title of this talk was What's Available and When to Use Them. And the key here is that these are expensive devices, which are much more expensive than a hearing aid. And they expose your patient to the risks of an operation and the risks of damage to their existing hearing. And they're therefore decisions that are made by a multidisciplinary team. Certainly if we make a decision about an implantable device, it's made by at least one surgeon and 1 or 2 audiologists. And it just means you don't have one person making those decisions, because these are potentially really important decisions for the patient. So I'll start with the Medel Vibrant Sound Bridge. This is one that you probably have all heard of. I showed you a picture of it earlier. There's an outside processor, so it's only partially implantable. It still requires an external processor. And the internal part has a magnet, a coil, and a little active bit here, which hopefully you'll see on a video in a bit. It functions by transmission of electrical signals. So this processor picks up sound from the outside world. It delivers electrical signals to the device on the inside, which then makes the active part vibrate against part of the middle or inner ear. Most often this is the incus. It can also be attached to the stapes or the round window. And if you look at the couplers that the company provides, they've made custom-made little clips where you can clip this device onto the short process of the incus, which is the commonest place to put it. It's very easy to do. Drill your mastoidectomy, stick it on, everyone's a winner. You can stick it onto the long process, and there's a slightly different clip for that. It can be attached to the round window if the patient doesn't have an acicular chain. And there's also a coupler for attaching it directly to the stapes. Okay, so there's a nice 3-minute video from the company. Here we go.
El Vibrant Sound Bridge es un sistema auditivo de implante de oído medio, adecuado para personas con pérdida de audición neurosensorial o pérdida auditiva mixta o conductiva. El Vibrant Sound Bridge es una solución para las personas que no pueden experimentar una mejora con audífonos convencionales o no puede usarlos por razones médicas. El Vibrant Sound Bridge, sistema de implante de oído medio, consiste de un procesador de audio externo y un implante que es colocado quirúrgicamente debajo de la piel. El procesador de audio se sostiene directamente sobre el implante por atracción magnética y puede ser cómodamente llevado debajo del pelo. Los micrófonos del procesador de audio recogen las ondas de sonido. El procesador de audio convierte el sonido en señales eléctricas. Estas señales se transmiten a través de la piel hasta el implante. El implante retransmite las señales a través del cable conductor al FMT transductor de masa flotante. El FMT convierte las señales en vibraciones mecánicas que establece las estructuras del oído medio en movimiento. La versatilidad del FMT ha llevado a una variedad de aplicaciones quirúrgicas, conocido como vibroplastia. La vibroplastia del yunque, por ejemplo, implica unir un FMT al yunque. Este procedimiento es un tratamiento para pérdida de audición neurosensorial. En la vibroplastia de ventana redonda, ve el FMT colocado en el nicho de la ventana redonda para el tratamiento de pérdida auditiva conductiva o mixta. El FMT también se puede colocar en diferentes estructuras vibratorias del oído medio con el fin de estimular su movimiento. La intensidad de las vibraciones mecánicas se puede ajustar a la pérdida auditiva del paciente. El FMT transfiere vibraciones al oído interno y al cerebro, donde estas señales se perciben como sonido. El éxito del Vibrant Sound Bridge como tratamiento para diversas pérdidas auditivas se puede atribuir a su diseño único. El implante solo está estimulando la estructura del oído medio a la que fue fijado. Esto hace que Vibrant Sound Bridge sea independiente del crecimiento del cráneo y por lo tanto adecuado para implantación en niños. La nueva generación del implante BORP SMR condicional en 1.5 Tesla, lo que significa que los procedimientos de imágenes no estarán comprometidos. El procesador de audio ofrece la última tecnología de audición que se adapta a los diferentes entornos y al uso de escucha individual. El control remoto asegura un fácil manejo. Posibilidad de conectividad inalámbrica habilita la conexión a teléfonos móviles y dispositivos de ayuda auditiva. Las cubiertas del nuevo procesador de audio pueden ser intercambiadas. El color o diseño se puede elegir para cada ocasión. Los usuarios pueden beneficiarse de futuras actualizaciones de tecnología. Esto resalta solo una de las distintas ventajas de este sistema auditivo implantable. Redescubre la audición con la última generación del sistema Vibrant Sound Bridge, el nuevo estándar en implantes de oído medio.
Okay, not sure why that cut out, but that was pretty much near the end anyway. So if we look at candidacy guidelines for these devices, you'll see from this pure tone audiogram here that they offer quite a wide candidacy in terms of pure tone audiology. And in fact, it's not the audiology that really swings the decision for these. So to be eligible for one of these devices in terms of sensorineural hearing loss, you have to have stable conduction thresholds. You can imagine if someone's got a deteriorating hearing loss, they might be in candidacy, and then as their hearing deteriorates, they drop out of candidacy and have an expensive device which is no longer any use to them and are in cochlear implant territory. They have to be over age 5, they have to have normal middle ear function. It's quite normal to do a CT scan just to look at the middle ear anatomy in order to figure out where the device can be attached. They need to have speech understanding of at least 50% in their best aided settings and to be able to benefit from amplification. They need to have an absence of retrocochlear and central auditory disorders and to be motivated and to have appropriate expectations for the device which they're going to engage with. As I mentioned earlier, this is also suitable for patients with a conductive or a mixed hearing loss, and for these patients there's a slightly different candidacy outline where they like to have bone conduction thresholds a little bit better, and air conduction thresholds can be anywhere. They need to be over age 5 again, have an absence of middle ear infection, have favourable anatomy, to be able to benefit from amplification, and once again to have no retrocochlear or central disorders, and to be adequately motivated and to have appropriate expectations. And this is really the role of the specialist audiologist that assesses these patients. It's slightly beyond what we have to do in our personal practice, but it's something that we should be very much aware of because if a patient commits to one of these devices, they have to have appropriate expectations regarding their outcomes. So the Vibrant Sound Bridge is one middle ear implant for which there is quite a great deal of outcome data. There was a 20-year systematic review carried out in 2016, The overall results demonstrated that the mean improvement in functional gain for the patients with a sensorineural hearing loss was 32.6 decibels, and for the conductive and mixed group was 27.9 decibels, and speech recognition also improved. This was in 6 months plus following implantation, from 44 to 84% in the sensorineural hearing loss group, and from 63 to 95% in the conductive and mixed group. The results for speech and noise are limited in that there are not a lot of published outcomes, and there are really very few publications reporting outcomes over 18 months, and hopefully that will change as time goes on and the body of literature increases. Any questions about the sound bridge before I go on to the Carina device?
So Emma, there's just one question. How will you confirm occipital fixity prior to considering middle ear implants?
Yeah, that's a good question. So that's something that will be measured via the pre-op tests, such as tympanometry and also the CT scan. You can't really measure ossicular fixity unless you're in there moving the ossicles, and therefore it would have to be yeah, looking at the results of those tests, making a sensible decision, and I guess measuring your patient's expectations. In fact, if there is a fixed ossicular chain, you can use an alternative. Let me see if I can go back. You can use the one that goes on the round window and completely bypass the. Oh, it's not letting me go back. And yeah, this one. You can completely bypass the ossicular chain if you need to. And I know a colleague has had to do that on one occasion and actually got a very good outcome.
And then from Eric Farrell, after insertion of the device like the sound bridge, is there a period of recovery before turning it on?
Yeah, so essentially this is a device which has an internal and an external component, and so certainly in our centre we like to leave things to heal for at least 4 to 6 weeks before applying the external device. There's also going to be some blood and swelling in the middle ear around the device, so letting that all settle down is more likely to give a good outcome once it's switched on at 4 to 6 weeks.
And then from Tom Milner, what's the advantage of a sound bridge over a Baha or a bone bridge device?
Yeah, that's a great question. As I mentioned earlier on, there are really limited numbers of these devices that have been implanted in the UK, and that's because the indications are very narrow for each device, and there is a lot of overlap between them as well. So there's not going to be one particular device that suits one particular patient. It's going to be a matter of the MDT weighing up patient expectations, patient needs, patient anatomy, and making a sort of organic decision.
And then from Hitesh Taylor, how do you assess able to benefit from amplification?
So these patients will have all had a conventional hearing aid. They'll have at least had a trial of it. But that's a good question. I don't know whether there's a definite answer to that. Maybe Simon can help me with that. Is there a definition for able to benefit from amplification, or is it just based on the trial of the hearing aid?
Simon or Simon?
Sorry, just switching everything back on again. No, I mean, the guidelines are, as Emma has stated, there's no specific criteria other than those. I mean, I guess the one thing to say is that the amount of amplification you get from the implantable devices often isn't all that much more than the amount of amplification you get from a hearing aid. It's just that you can wear the implantable devices if you've got ear canal problems, whereas the hearing aids obviously cause issues. So you need to be a bit careful about interpreting the literature in terms of the amount of functional gain you get from the implantable devices.
Great, thank you. Just as a quick note, obviously the chat function is still going down the outside. We now have Anand Kasbakar, one of our colleagues in Nottingham, chipping in as well. So I am going to be saving the chat so everyone can read it back, because there's a lot of good stuff going on in there as well. So thanks, Emma. Okay.
So moving on to the Cochlear Carina device, this is an active middle ear implant which is totally implantable. This means there doesn't have to be an outside part, it's all inside the body. And this allows the patient to hear whilst they're sleeping, showering, or doing some sports. And if you look at the international use of this so far, for example, in Germany, they're really using it for lifeguards and swimmers and people that have this sort of lifestyle where they would really like to have something totally implantable. In the UK, where we have an NHS, it's difficult to justify that. So we haven't actually implanted very many of these so far. We've done a couple in Manchester, and the patients we chose have done very, very well with them. But the theory is they allow you to hear whilst you're doing all these things, and therefore they're more of a lifestyle option. So this is the microphone, which is implanted under the skin. This is the part that touches the incus, and I'll show you a video of that shortly. And the battery pack is all inside the implanted part. In order to charge the battery up, the patient has to charge themselves up for, I think they say 40 minutes a day, and a lot of patients who have them tend to do it when they get up in the morning or when they're in their car on the daily commute. They just attach the magnet and charge up. So there's a subcutaneous microphone which picks up sounds, and then it works in a similar way to the other implantable devices, and in that the microphone converts sound to electrical energy, and this then sends it to the actuator, which pings mechanical energy against the incus. It can also be connected to the stapes. We haven't done that yet in Manchester, but some centres have attached this to other parts of the ossicular chain. In terms of candidacy, audiometrically, the companies say this goes right up to cochlear implant territory, so right down to 80 decibels. The indications of patients who can't wear their hearing aids or who are dissatisfied with the result from their hearing aids. It's only licensed for people over age 14, and again, with no medical contraindications. So I think I've got you another nice video to watch. This one's just 2 minutes.
If you are experiencing a moderate to severe sensorineural or mixed hearing loss, a cochlear carina system may be a possible solution for you. It consists of an implant, a remote control, and a charger. The implant includes a microphone, an actuator, an electronic module, a battery, and a magnet. This is how it works. The microphone is implanted under your skin. The implant body is placed just under the skin behind your ear. The fixation system holds the actuator in place. The actuator, which acts like a tiny motor, touches one of the ossicles in the middle ear. The microphone captures sound and sends it to the implant under the skin. The implant then converts these sounds into an analog electrical signal. This signal is sent to the actuator in the middle ear. The actuator translates the electrical signal into a mechanical motion that directly drives the ossicles, enabling you to hear sounds in a more natural way. The remote control allows you, if you are experiencing...
Okay. So there are some disadvantages of a totally implantable device, and these cover some of the reasons why it hasn't yet become as widely used as you might expect. It sounds very, very dramatic and very earth-shattering to have a totally implantable hearing aid, but it's not without its own issues. This is a clinical photograph of the first one that we did in Manchester. This is the level of the middle fossa dura. So this is the fixation device and the actuator heading in there towards the incus body. This is the microphone, and it's a really lovely device, and it seems a shame to stick it under a big flap of soft tissue and skin and have it covered in blood, but that's what the totally implantable device is. The patients that we've done so far reported a lot of amplification of their own body sounds, which they didn't like, but that actually eased off after the first 3 or 4 weeks, and they now really, really like their devices. The battery pack in the implantable device lasts 10 to 15 years, so patients who go ahead with a Carina totally implantable hearing aid do so on the understanding that they'll likely need revision surgery to replace the battery in 10 to 15 years' time. And the manufacturers have made it in such a way that you can leave all the other bits in and just change the battery. If the hearing thresholds are worse than 80 decibels, the patients require an external processor for additional amplification. In actual fact, since the Carina came onto the market, the cochlear implant guidelines have changed. So patients who have decibels worse than, thresholds worse than 80 decibels are now going to be in cochlear implant candidacy anyway. One of the things you might notice from this picture is that there's a lot of hardware, and it's really quite bulky, and although it's made very elegantly and very nicely, you do just get the feeling when you're closing up that there's a lot more hardware than you'd normally implant. And actually our patients so far have healed up very nicely. Any questions on the carina before we go on to bone conduction?
Yes, from Areola, can you have middle ear implants, cochlear carina privately in the UK currently, if not eligible for NHS?
Yeah, good question. So theoretically, yes. However, the company have a couple of rules that they like people to follow. One is that because this is a very new device, you have to build up a certain amount of experience before they'll let you go solo. So there may well be a couple of surgeons in the UK who are doing these privately. The device costs the same as a cochlear implant. The internal part is about £12,000 and the external part is about £6,000. So theoretically, yes, but because of the limited experience in the UK, there may not be many surgeons offering this if that's what you're looking for.
Great, and that's, oh yeah, and Hugh's asking, how do you charge the cochlear carina? Is it similar to wireless mobile phone charging?
Yeah, so it's, yeah, I think it is actually. I think it's exactly like that. So the magnet on the inside attaches to your charger, and it's the two coils that I don't know really. Yeah, it's the same as wireless mobile phone charging, but I don't know the exact mechanics.
Great, thanks Emma. That's it for now. Okay,
great. So moving on to bone conduction hearing systems. This is a technique that you guys will probably be more familiar with. As I mentioned earlier, I still find bone conduction quite magical. I give talks at my children's schools about the human body, and I always take a tuning fork and show them there's two ways to hear. One is via your ear and one is by your skull. And children think it's amazing, and I must say that I still do as well. The theory is that you can vibrate any part of the skull. You guys will know if you put a tuning fork anywhere on your head or your teeth, you can hear the sound. And that's because vibrating your skull causes some oscillation of your perilymph, which leads to a perception of sound, and I just think that's fantastic. So it bypasses the external auditory canal, the tympanic membrane, and the ossicles, the entire middle ear. It sends sound straight to your inner ear. So bone conduction hearing systems are effective in the treatment of conductive and mixed hearing losses. These are most commonly disruption or fixation of the articular chain, external auditory canal atresia, or a chronic otitis externa where patients can't wear a traditional hearing aid and benefit from bone conduction because of a conductive or mixed loss. About 15 or 20 years ago, there was a vogue for using bone conduction to treat single-sided deafness. And this has essentially been useful within a limited group of patients because it doesn't provide binaural hearing. If someone's lost their hearing on one side and you stick a bone conductor on, you guys will know that bone conduction sends sound to the better hearing ear. So it essentially reduces the head shadow on the deaf side, but it does not provide binaural hearing. In my personal experience of meeting patients with a single-sided hearing loss, if they've gone suddenly deaf, they do not like having a bone conductor on the deaf side. And if they're long deafened, they really like it because it gives them some sound from the deaf side, which they haven't had for many years. The nice thing about bone conduction hearing systems is that you can give them a trial of a bone conductor, either an adhesive one or one of the headbands that they can try prior to going ahead with surgery. So as I mentioned earlier, you can divide bone conductors into percutaneous and transcutaneous. The percutaneous ones are the ones you guys will be most familiar with. It involves putting a titanium screw into cortical bone of the skull. There are special drills which you can create your hole with, check that you're not onto the dura, doesn't actually matter if you are, put your device in, and once it's healed up, you can put a hearing aid onto that abutment. This is categorized as active because the hearing aid that you stick onto this abutment picks up sounds and transmits them directly to the skull. These have become a lot less hard work than they used to be. Certainly when I started out in ENT over 15 years ago, consultants were thinning down the soft tissue because there was a belief that the titanium abutment had to be in bone and fairly free from soft tissue in order to get a good outcome. In fact, we now know that this soft tissue doesn't dampen the sound transmission at all. And so this is now a very easy operation. It can be done under local anaesthetic in about 10 minutes. In terms of candidacy, this is an image from one of the companies, which I think shows candidacy very nicely. There are different powers of processor. So the titanium bolt in the skull transmits the sound, but the power of the sound processor that you fix onto it determines how you can access that sound. So they don't recommend bone conduction devices if your thresholds are worse than 65 decibels. Transcutaneous bone conduction, some of you may well have come across as well. There's no abutment sticking through the skin. There's an internal magnet which goes into the bone and has a skin flap which heals over it. And the sound processor is attached via a magnet. And these two magnetically attract to one another and with a layer of skin between them. And this is therefore categorized as passive because it's sending the signal through the skin before it gets to the important bits. Disadvantages are, of course, there's dampening of the vibrations. These apparently cause loss of 5 to 15 decibels, which are worse than high frequencies. The advantages are that there is a much lower risk of skin problems and that the patient can take the processor off if they want it to look as though they're not having, as though they haven't got a device at all. The third type of bone conduction implant is a bone bridge implant. These are devices which have an internal and an external component. They aim to combine the advantages of the traditional percutaneous by having part of the device in the bone of the mastoid, and the transcutaneous device, therefore avoiding any skin problems and the device being invisible when the processor is taken off. So essentially there's a signal produced by the sound processor which transmits sounds directly to the skull, vibrates the skull. Advantages are that patients seem to do well with these if they're chosen carefully. There's not a great deal of outcome measures at the moment, and it's a very expensive device and needs to be selected very carefully. It's also a fairly invasive operation, less so more recently, because whilst this has to be recessed into bone in order to vibrate the skull, you can see on this X-ray that the original device, which you can see here, was very thick and deep, and it's now about half that thick. So up to a year ago, it was really necessary to do careful pre-op assessment as to whether your patient could anatomically take one of these. And certainly one of my colleagues has asked me to come into his theatre and take the bone off the sigmoid sinus so that he could completely depress the sigmoid sinus to get a bone bridge in. With a new device, which is half as thick as this one, it takes away that problem and probably opens up this option to more patients. So in terms of candidacy, patients for bone bridge implant need to have conductive or mixed hearing loss with bone conduction thresholds at about 50 decibels or better. They need to be over age 5, and that's essentially an anatomical thing. They need to have favourable anatomy, an absence of retrocochlear and central auditory disorders, and again to have adequate motivation and expectations for the device. Any questions about bone conduction before we move on?
Yeah, hi Emma.
Hiya.
So, from Sarah, why do you think patients with sudden unilateral loss don't find a BAHA helpful?
So this isn't science. This is my personal opinion. And if you offer a bone conductor to a patient who's suddenly lost unilateral hearing, they're expecting to get their original hearing back. And they're disappointed that what they have is not their original hearing, it's some sound being taken from this side of the head and delivered to the good ear.
And Mark is asking, just to clarify the audiological criteria, it seems that BAHA and middle ear implant are essentially equivocal for CHL and MHL, and therefore patient choice. But if the central neural hearing loss is not reaching CI criteria, then middle ear implant is the best option. Does he have that right?
Yeah, I suppose he does, yeah. So this is one of the issues with these devices and why there isn't a massive cohort of them, because if you think about an implantable hearing aid, it sounds really magical. You'd think it would be the thing everyone will go for. But in fact, there's a very narrow cohort of patients whom it suits. And it is down to patient choice in some respects. But also, as I mentioned earlier, if someone's hearing is deteriorating, they might only be in that window for an implantable device for a short amount of time. So it's really about choosing your patients very carefully. They'd have to have stable hearing thresholds within the candidacy criteria in order to qualify.
Great, thank you, Emma. And we can. Oh, and Ashley is asking, why choose bone bridge implant over a transcutaneous BAHA?
Yeah, that's a great question. When I first heard about bone bridges, I wondered exactly the same thing. Well, the idea is that it combines the two options. So it gives you the advantage of not having something sticking out through your skull, and reduces skin problems because it's all under the skin and attaches just with a magnet. But it doesn't have the same dampening problems as the transcutaneous device because it's in the bone as well. So although they might be subtle benefits, there's a small cohort of patients who are looking for exactly that. And that's why we come back to patient selection. And to get good outcomes from these devices, we need to choose the patient very carefully before going ahead.
Great, thanks, Emma.
Okay, so coming to the end actually, so we might get back onto track a little bit. To recap about implantable hearing devices, these are devices which are indicated when patients can't use or don't benefit from their conventional hearing aid. There are three main categories. These are amplification devices, bone conduction devices, and ones which bypass the inner ear, the outer ear altogether, which Simon will tell you about shortly. The amplification devices are suitable for any type of hearing loss. They can be partly implantable, and you've heard today about the vibrant sound bridge. They can be fully implantable, and I've mentioned the pros and cons of the Carina device today as well. If we look at the bone conduction devices, this can be percutaneous or transcutaneous, and they can be active or passive. The BAHA Connect is the traditional one. This is percutaneous and active. The BAHA Attract is the magnetic one. This is transcutaneous and passive. And the bone bridge is the combo version, which is both active and passive. And it's both percutaneous. Well, it's transcutaneous, I guess. So in terms of perspective for the future, some of the questions that have come up today have been very astute questions asking about candidacy and device choice. And with hearing aids improving all the time, a cochlear implant candidacy widening all the time, it does make you wonder, what is the role for these devices in the future? But for the time being, as we sort of mentioned today already, this is about MDT decision making and careful patient selection and choosing the right device for the right patient. Thank you very much.